Welcome to our webinar called Discovering Collaborative Solutions to Control Municipal Healthcare Costs. I am Mark Levine, and I'm the Deputy Director of your New York State Association of Counties. Our topic today will feature an informative webinar highlighting the Municipal Healthcare Financing Collective, a county consortium established a little over 5 years ago to offer innovative stop-loss captive solutions for self-insured counties and municipalities. The MHFC was created to enable self-insured counties and munis to pool resources, providing robust protection against high-cost healthcare claims. Through collective monitoring of losses and active management of provider claims, the MHFC empowers members to contain costs and improve transparency. Today, we're going to talk about this unique program and how it's helping counties and taxpayers achieve financial stability while optimizing risk management strategies. We're going to talk about what the MHFC is and how it works, the unique advantages for counties, and how participation can enhance your risk management and cost savings. Before we get started, I want to turn things over to Kate Pierce, NYSAC's multimedia specialist, who's coordinating today's webinar. Kate.
Good morning. So a couple of housekeeping announcements. First is that this webinar is being recorded, and the recording will be posted along with a PDF of the slide deck on NYSAC's website at nysac.org/webinars. They're organized by date. The recording can also be found on NYSAC's YouTube channel at NYSAC TV. We encourage attendees to submit questions for our presenters at any time during the presentation by clicking on your dashboard tab entitled Questions. Questions will be addressed at the end of the webinar during Q&A. And back to you, Mark.
Thank you, Kate. Before I introduce our speakers today, I'm going to get things started with the presentation. Mark, next slide, please. I'm wearing two hats today. I will serve as the webinar's moderator, and I encourage you all to ask questions throughout the presentation. I will take up those questions at the end of the presentation in the order that they came in. So please, if something begs a question for you, type that into the dashboard, and we will get to it at the end of the presentation. So I'm serving as the moderator, but also NYSAC's liaison to the Municipal Healthcare Financing Collective. I have been working on this program with our participating counties and partners since its inception. So I wanted to start things off today by giving you some background. On August 15th, 2018, 4 counties in the Tompkins County Healthcare Insurance Consortium signed an IMA, an intermunicipal agreement, to form the Municipal Healthcare Financing Collective, the MHFC. This was created as an entity to explore ways to stabilize or reduce the cost of healthcare insurance for self-insured counties and eligible municipalities. The initial focus of the MHFC was to explore and reduce the cost of stop-loss insurance, which is a sliver but a costly piece of the health insurance expenses for our self-insured counties. NYSAC has been working with the Alera Group, formerly the Ralph Benefit Advisors, or RBA, since early 2017 to develop this program. Alera had created a similar program for a collective of small colleges in New York, and the members of that collective had received returns of premium each year that they have been in operation. So what is this, right? The stop-loss program is a combination of traditional stop-loss coverage and the participation in a stop-loss captive. So it's a combination of both getting stop loss coverage and participating in a captive. The captive layer covers claims up to $400,000 for each participating entity high claims threshold, with claims exceeding that layer being covered by a traditional stop loss insurance carrier, in our case, Berkeley. The amount of funds remaining in the captive layer after the physical claims are all paid are returned to the municipal members on a pro rata premium share. In 2 of the 5 years that we've been in operation, our participating counties have received a dividend or a pro rata share of their premium. NISAC is very active, expending considerable staff time and resources in the creation of and operation of the MHFC, including the creation of the IMA and the bylaws, and being an ongoing liaison between members of the collective, the Alera group, and the stop loss insurance carrier and captive. We meet 3 times a year to discuss claims experience, how to best manage high cost claimants, and discuss the financial situation of the captive. So I'm now going to introduce our speakers, and our speakers are from Alera and a county, and they participate in these 3 times a year meetings very actively, and they are a key piece in the self-management and governance of the MHFC. The first is Mark Polinsky. He's an executive benefits consultant for the Alera Group. Mark has over 25 years of experience specializing in strategic benefit planning for nonprofit organizations and municipalities. His expertise includes designing customized benefit packages aligned with union agreements to offer cost-effective and competitive solutions to our members. In this case, that's what he's going to be talking about. Julie Coopers is a PhD, an NP, and an RN, and she's the Vice President of Clinical Consulting and Advocacy for the Alera Group. She's a board-certified family nurse practitioner and accomplished leader in the field of population health. She earned her PhD in health science from the University of Rochester and has been funded nationally and regionally for her work on health promotion and disease prevention strategies. She has extensive experience in public health, health systems, and data analytics, and she brings that to the MHFC every day. And we hear about it 3 times a year during our meetings, and we're pleased to have her expertise on the program and with us here today. And finally, Kevin Roach, who's the Employee Benefits Administrator for Ulster County. He has been with the program since inception, and Kevin is here to talk about the experience that Ulster County has had with Alera and the MHFC. Thank you for joining us today. And I want to take this opportunity to turn over the microphone to Mark Polinsky, the Executive Benefit Consultant for the Alera Group. Mark.
Thank you, Mark. I appreciate it. And just one house cleaning. I just want to make sure, do we have full screen working right now? Can you see my
yes,
the mouse?
Your slideshow. Yes, Mark. Yes.
And you can see the mouse because I usually go to where it is. So am I underlining NISAC right now?
You are, yes.
Okay,
you are
great.
in control of the presentation. Take it away.
Great. All right. Oh, wrong direction. All right. So what is the MHFC? Oh, and one other thing for everybody. I want you to feel totally comfortable at any time to just go ahead and ask a question. It will make the presentation work better. So don't hesitate to do that. Type in your questions and we can see those as we go along as well. And we'll check in periodically with you on that. But what is the MHFC? It's simply a member-owned stop-loss captive, right? And as Mark alluded to, it was developed years ago to bring everybody together for that benefit. So what is a captive? Technically, right? It's an insurance arrangement where employers form a captive to collectively purchase stop-loss coverage that protects them against unexpected large health claims. Basically, you're coming together, you're creating a way to protect one another for your bad years. Everybody's going to have a bad year. Some years, 2 two of the members will have a bad year and one of them will have a good year and vice versa, right? It happens. High cost claimants are volatile. There's just no way around it. So who can join? And we'll get into more details. I'll explain exactly how all this works. But in general, that's what it is. Everybody coming together to protect one another on their bad years. So who can join the MHFC? Any fully insured municipality with over 100 eligibles. That's a New York State law that they have to have over 100 eligibles. And a municipality could be a town, a village, a city, okay, any of those types. And anybody currently self-funded, a self-funded municipality. And looking at those of you that registered, we have people that are fully insured, we have people that are from the counties, and we have people in all different positions within the county. And so I'm trying to make the presentation so that I can address all of your needs and where you might be coming from your positions. So if you have questions, don't hesitate to ask. All right, what are the benefits of a municipal captive? Well, the advantage of a stop loss captive versus standalone arrangement. Standalone arrangement, if you're not currently in a captive, is how you currently get your stop loss coverage. You get it every year. Whoever you're working with probably goes out to market, shops it out, brings it back, says this was the lowest price. And you may have the same carrier from year to year. It may change. That's what we mean by standalone, okay? And if you're in the captive, what advantages of it is you get control. And that's important. It's member-driven governance. That's what Mark talked about in the IMA being developed, but not just in that part of it. It also allows you to make decisions on the structure and how you want to manage the risk within the captive. So you have more control than if you just shopped it and then whoever the stop loss carrier, you depend on what they do. So you can take a more proactive role in controlling your costs. We're pooling the risk, all right? And that gives us cost stability. And that reduces the volatility and helps absorb the bad years. And it takes away some of that variability of a standalone contract. If you have a bad year in a standalone contract, you usually pay the price the next year. And then hopefully it comes down, but that doesn't usually happen. And you end up on a perpetual increase. Or for those of you that are familiar with stop loss, you change your deductible to bring the premium down. So you take on more risk. So what are the benefits of a municipal captive is that you would share that risk with other counties and then reap the benefits of how the captive in total performs, okay? The other is you have full transparency on all the data and all the costs. That allows you to make data-driven decisions and be proactive in the risk management strategies. And Julie's gonna talk a lot about that. And then collaboration and shared best practices. If something's working in one county, we can collaborate with another, or we can put programs together when we're looking at the collective data to say, hey, what is it that this disease burden is, and can we put a program that helps everybody? So it acts as a collaborative way to do that. So that are the benefits of the captive. All right, why come together though? Like, do I have to? Well, only if you want a couple things. By coming together, you get a couple things. You get control. You're able to maintain your autonomy, and you're able to use the leverage of being part of NYSAC in 62 counties in New York State. So the control, I have already alluded to. Julie's going to talk about real-time risk management of the high-cost claimants and the control we have there. We already talked about the structure and the things you can do. But autonomy is important. And having worked with many municipalities throughout the years, one of the things that's really important is everybody wants to do their own thing, and they have existing plan designs. They have existing eligibility. Union negotiation terms are different from county to county. They're different within each organization between unions. There's contribution differences. There's risk tolerances between the different counties or municipalities. So how do you maintain that? That's what the program was designed to do, to give you guys control and to give autonomy or allow you to maintain your control. So you get to keep your existing medical plan carrier, or if you have a TPA, you get to keep the PBM that you're currently using, your pharmacy benefit manager. and no change is required to participate in the MHFC. You have full transparency of all the data and the costs. Julie will share with that. And then most importantly is the stop loss premium is underwritten by the individual municipality. Simply said, every municipality is underwritten separately, even though they're part of the MHFC. And I'll show you a little bit later how that works. But I want you to understand that what's not happening is you become part of this and everybody gets the same rate. And the reason for that is it doesn't make sense. Not every year are you the same risk with your high cost claimants as another municipality. And so it shouldn't be socialized. It shouldn't be done that way. And this captive is not run that way. And so that's important. So that allows you to maintain your autonomy. And that way, any county that's doing a really good job of controlling high cost claimants, they're going to have lower premiums than another that doesn't do a good job with that. So we thought that was important. The other is obviously leverage. 62 counties would be the desire of any carrier. So coming together does give you leverage. It also provides that any municipality that is currently fully insured, that you could consider moving from a fully insured model to the self-funded model under the protective stop loss environment that the captive provides. The underwriting for the captive is to break even versus a standalone contract, which the stop loss is written for profit for that stop loss carrier in that given year. Two very different perspectives on how to underwrite risk. Lastly, the leverage does provide financial stability with predictable cost and protection from the market volatility. You will see how the captive has performed and done exactly that for its members. And then let's assume that they underwritten it to break even, but everybody had a good year. So the premium that you paid into the stop loss carrier captive exceeded what the actual risks were and the claims were. What would happen? Well, in a standalone contract, the carrier would keep that profit. In the captive, any underwriting gains are returned to the members on an annual basis. They're not accrued over time. They're not held back. They're returned. So it is a very transparent, it is a very, from our perspective, a logical way to handle risk and allow everybody to participate with maintaining their control and using leverage that you have. The results are long-term savings, the ability to outperform the commercial stop loss trends. All right. So that's why you would come together. Those are some of the benefits of coming together and what you could expect or not have to give up, in other words. All right, so let's talk about real quickly here, the standalone stop loss versus the captive. All right, on the left-hand side, we have the stop loss right here. It's very simple. For those of you not familiar with stop loss, generally you pick a number that you want to cover as a municipality. In this example, we said any claims between $0 and $100,000 per person, the municipality is going to pay for. If a claim exceeds $100,000, the stop loss carrier will then pay the claim, and you pay premium for the stop loss carrier to pay that claim. So that's how standalone stop loss works. Okay. And this number, I arbitrarily picked 100,000, could be 150, 250, any number you want, it can be. So that's how standalone has two layers. What did the municipality agree to pay? Anything above that, the stop loss carrier pays. In creating the MHFC captive, you'll notice that there are three layers. The teal layer is the same. Municipality still pays claims 0 to 100,000. And then the MHFC layer is going to pay claims between 100 and 400,000 in this example. Any claim that exceeds 400,000 would be covered by the reinsurance carrier. So that's how an individual works. Okay. And it's really that simple. So this MHFC layer is the layer that each of you municipalities are taking the premium that they're paying for the stop loss and they're seeding it to this layer. They're saying, okay, stop loss carrier, you want X amount of dollars. We're saying take of that premium, take a certain amount and put it in our layer, and we're going to pay claims out of that. And so no matter what organization has a claim in that layer, it's paid out. At the end of the year, if there was enough premium in that layer, then it's returned to the members. If there's not enough premium in that layer, that's the maximum exposure for the participants. And that has happened on numerous occasions throughout the history of the captive, where the layer here was exhausted, the maximum liability was known before the year started, no harm, no foul. This green area is what we call the collateral, and that is part of this middle layer. So you pay the premium and you set a little bit aside for those years that maybe it will exceed what was anticipated in collateral. And also in the captive environment, you're able to ensure protection for the individual, but you're also able to say, I need protection for the total claims that I might incur in 1 year. So as an example, let's say an organization had $4 million in claims, average $4 million in claims in the last 3 years, okay? The stop loss carrier would say, okay, do you want protection for a maximum of what your claims will happen? And they'll say, yeah. If you said yes, then they'll give you a maximum amount and you pay a charge for that. It's called the aggregate charge. You can decide to have aggregate coverage or you can decide not to have aggregate coverage. Either way, you're protected 100%. So you have always a maximum exposure for an individual, and you have a maximum exposure as an organization. And that's important for those of you that might be considering moving from a fully insured model to a self-funded model, because you would know what your total risk is in any given year, and you could insure to that based on your risk tolerance. So the captive allows us to do that in a very friendly way. Again, autonomy and risk management philosophy. Each member of the captive chooses their own stop loss deductible and if they want aggregate. So in my example, the stop loss that was chosen was 100,000, but as I said, one group may want 150. Maybe they say they want claims paid, they'll pay claims up to 200,000. And any number of people can do that. Any number of the municipalities can do that. It doesn't matter. There's no restrictions in what you can do as an individual municipality by participating in the MHFC captive. Okay. Now, for those of you that have been doing stop loss for a while, you may have heard of captives before. In general, there's two types. There's the homogeneous, which is all one type of industry, higher ed, not-for-profits, municipalities. We have captives, we manage captives in higher ed, in not-for-profits and municipalities. That is what we think is the best for those types of organizations. There are others out there available that has mix of employers. So you could have manufacturing, municipalities, not-for-profits all in a captive. What we have found is birds of a feather flock together and they think alike. And so if you keep people who think alike together, then the decisions they make are usually in unison of what's in best for the collective group. When you mix that up, people tend to think of their own self-interests. And if one group is performing maybe poorly for several years, they get an attitude of maybe we shouldn't have them in the group anymore. Where a homogeneous group does not think that way. They understand that their time is coming, and by working together over a longer period of time, it should all shake out. Any questions on the captive and any of the issues that have been raised at this point? Okay. Unique advantages for your municipalities, both fully insured and self-funded. One of the things that I wanted to point out is that, and this is a chart from the Kaiser study, and this here is 200 to 1,000 employees or workers. 61% of organizations that fall into that are self-funded, and that may be surprising to some of you. And then any groups that are 1,000 to 5,000, 81% of them are self-funded. So if you fall into this category and you're not self-funded, it's likely that being self-funded would benefit you, and participating in the MHFC is probably one of the easier ways to accomplish that, if you haven't considered it up to this point from a risk mitigation perspective. So the MHFC is open to both of those currently fully insured and those currently self-funded. All right, the MHFC, it provides you control and autonomy. But how does it compare to the other programs? The other programs that are available, like the trust, the Compton County Trust is one of those examples. There's Article 47s out there that you could participate in. For those programs, the program selects the vendors. So if you're going to participate in those programs, they've selected the vendor, and then you have to use that vendor. In the MHFC program, we are vendor agnostic for your medical and pharmacy. It doesn't matter. You can have any of those. They could be with the same carrier. They could be different. It doesn't matter. You have control. You have autonomy. The program chooses the plans to offer, gold, silver, bronze, or whatever the designs are, and they set the rates, and the rates are set by the experience of everybody. They're fixed. So if I'm large or small, or if I happen to be performing well or poorly, my rates are the same. Within the MHFC program, you choose the plan design, and every organization gets individual stop loss rates. In the program alternatives, there are potential for multiple year commitments, and if you leave, there are potential liabilities that you will have to repay for by leaving early. Under the captive, the MHFC captive, there's no commitment required. There's no exit or termination barrier or terminal liability. So all of those are available. You have all the autonomy and control that you want. All right. So that's how the programs are different, right? And how has it performed? Well, resilience beginnings are captive steady performance through unprecedented times. Sorry about that. We went ahead. All right. So resilient beginnings, if you'll notice, we're going to focus on these two columns right here to begin with the chart. I'll explain the whole chart, but we've outperformed the industry averages throughout the program. All right, so in 2020, we started the program. Well, if we had known the pandemic was coming, we probably would not have started it, right? But it got all put together in January 1, 2020, pandemic hits. At that time, we had about 2,000 employees in the program, 3 different organizations, which are Columbia, Ulster County, and Yates. And in 2021, 2016, if you remember, as the pandemic, you saw a lot of your employees, your number of employees you guys had decreased. In 2022, they decreased. In 2023, they decreased. And in 2024, they decreased, and we started to see a turnaround in 2025 of enrollment, right? Everybody knows that. Everybody knows they had no appetite for risk in 2021, 2022, 2023. They had no idea what the pandemic was doing to their claims. Claims were suppressed. It just wasn't a great environment for people to say, yeah, I want to join a captive or do something different with their healthcare. They just wanted their employees to be covered, and were batting down the hatches. So what happened during that time? Well, the average per employee per month cost for those in the captive was $65. It went to $68 in 2021 for a 4.7% increase. It went to $74, it went up 8.9, 84, 13.2, 89, 5.8, and now 93 or 5.1, okay? So those are modest increases. When comparing those increases to what the industry averages were doing, right? Those are all better than what the industry averages at that time, or very close to it. And this yellow column, this blue column, is the inception to date change, the average for everything. So you can see that despite being in a very difficult environment, having just 3 members in the captive, that the way the captive is constructed, the way that it has been underwritten, that each group is underwritten individually, The years that one member had a bad year, the captive saved them. And then the next year, it was the other person's turn. And it worked beautifully, and it has done great for the groups that have been involved in it. So is this typical? No. But we did want to just show you real quickly our college captive. And in our college captive, if you notice, it started in 2014. Colgate, Hamilton, and St. Lawrence, and they were all fully insured to start the captive. They had 1,300 employees, 640, 580. You can see their budgets. You can find a school on here if you want to what your budget is and your size, okay? Yates County, as an example, has about 170 enrolled. So that's why we mean anybody that's fully insured could consider moving to the MHFC and being self-funded. But if you'll notice, the red line here is the first 5 years of this program. It has 5 schools, 3 when it started, 1 in 16 and 1 in 18. So in the first 5 years, they picked up 1 every other year. In 2019, they added Vassar, these others. 2021, they added 1 college each. 2022, they added 2. In 2023, they added 3. And in 2024, they added 2. And then in 2025. In the last 3 years, from 2023 to 25, they've added 9. And so it just took a while for these colleges to start talking amongst themselves and sharing their positive experience. And there was enough track record for that to prove out. And you can see that the mix of those coming from fully insured and self-funded is fairly represented. So I just wanted to highlight that the better days are definitely ahead, and we would expect the growth to continue over the next 5 years. All right, working as designed. What do I mean by working as designed? It's underwritten to break even. So I want you to think of it as the whole box is the captive. You pay the claims here. The MHFC layer pays high cost claimants here. And then the reinsurer pays claims above these 2 levels. So in 2020, the captive had a loss, the total captive, of $159,000. But notice that the members had a loss ratio of 84%. Well, how's that possible? Because the members are only concerned about this layer and the premium that they put in this layer versus the premium that they paid. This total captive, right? So if we had $1 million claim for illustrative purposes, obviously it would exhaust for that one person, right? 400,000 of the million would be attributed to this captive layer. And then the remaining 600,000 would be covered by the reinsurance carrier. So the total captive could have 159,000 loss, but a majority of it is up here and not necessarily here. So that's what it means when we say we had this kind of loss in the year 1, but the loss ratio was here. In 2021, there was not a captive loss. There was excess premium. So the members were returned premium, and you can see that their loss ratio was 60% as a result. In 2022, they hit their max, which was allocated, which was the premium allocated for this corridor. It was exhausted, and they had about an 82% loss ratio, written for break even. And 2023, we had a $295,000 surplus, and money were returned to the members because we had a surplus. Too much premium was collected in this corridor and then was returned to the members on a pro rata basis. And in 2024 was not a good year, and there will be no monies returned. We did exhaust this corridor. 25 right now is running about neck and neck, and it's always difficult. In any given year, claims come in at different times, so it's difficult to know where it's going to be. All right. Before I turn it over to Julie and how she manages real-time risk management, how she manages these high-cost claimants, are there any questions about anything about the structure, participation, or anything like that we covered so far?
Yes, Mark, a couple of questions that came in, and since you invited these along the way, our current stop loss policy renews on July 1st. Since its inception, would it be possible to have adjustment of 6 months in order to join the MHFC effective January 1st?
The simple answer is yes.
Okay, that was easy. In the comparison slide of the rates to industry standards, are the rates of MHFC based on the $100,000 rate? Is the $100,000 the standard for all participants? I'm assuming that's the low end. Do you want to go back to that slide and then answer that question, Mark?
Yes. So this average rate is for the members of the MHFC currently, of the 3 counties. Each of the counties has a different attachment point. The stop loss deductible is different for each of those. And they range from 100,000 up to 400,000. And so this is the average rate for the total premium collected in the captive based on the total number of participants.
Okay. Do we have an industry standard for that number?
It depends on the size of your organization.
Okay.
Goes by size of organization.
All right. Kim, if you want to send me the size of your organization, we could probably, I'll send you an email in response, or have Mark send you an email directly in response to that question.
Yeah, it's probably better as a conversation. Yep.
All right. Thanks, Mark. I think you're about to introduce Julie, but I'll turn it back over to you.
Yes, thank you, Mark. Julie, are you ready?
I'm ready.
All right, you go ahead.
Thank you. So if you want to flip to the next slide, Mark. So our clinical team helps control costs by focusing on these 3 areas: high cost claimant analysis and forecasting, real-time risk management of high cost claims, and assistance with stop loss negotiations. And the reason that our clinical team focuses so heavily on high cost claimants is because while they're typically only a very small proportion of our population, they account for a significant amount of our plan spend. And as you can see from this chart from the Kaiser Foundation, which looks at national medical expenditure data, the top 5% of our membership typically accounts for about 50% of our plan spend. So just putting that into context, if you have a plan with 1,000 members, we're talking about 50 people accounting for half the plan spend. So if we can make a dent in even in that group of people, or even just a small subset of those high cost claimants, that could have a remarkable impact on our total plan spend. So in order to analyze those high cost claimants, we use a data analytics platform called Springbok to analyze medical and pharmacy claim information. And what that means is that we receive data from our vendors, meaning our carriers and our TPAs and PBMs. We receive that on a monthly basis. And this data includes claim line details on every claimant, meaning which office visit they had, hospital visits they've had, every treatment they've received, where those treatments take place, and the cost of each of the treatments. And we use that information to determine the exact diagnoses and treatments for all of our high cost claimants. And then we can help forecast future treatment and expected costs based on clinical guidelines. So on that next slide, you can see a good example of one of our high cost claimant reviews. So this may look pretty similar on the left side of this chart to what you might have seen from a carrier report when they're talking about high cost claimant reviews. So you see that current diagnosis for each claimant. You might see their total plan paid amount. On occasion, I've seen the carrier reports break down medical and pharmacy paid for each of the members, but generally we still don't have a great idea of what it is that the plan spend is going towards. And that's where our clinical team can help. So when you see the clinical notes there, which is that colorful column to the right, those notes are derived from all of those claim line details that we were talking about receiving in from our vendors into our data analytics platform. Now, our clinicians go through each of those claim lines for each of these claimants, and we try to provide a 1 or 2 sentence synopsis on what's going on with each of the claimants in terms of their diagnosis and treatment, what the cost of those treatments are, and then just using clinical knowledge of clinical guidelines, we are able to forecast out what that anticipated cost is for the plan over the next 12 months. We then color code each of the claimants to help our plan sponsors see exactly who's the highest risk from a financial standpoint, How should we budget going forward? And of course, we use this information also to help develop strategies. So as you can see from that top claimant, just as an example, this claimant has a diagnosis of multiple myeloma, which is a form of blood cancer. And they are on a combination treatment of Kyprolis infusions, which is a targeted infusion that's given every 2 weeks, and an oral medication called Revlimid. Now, the cost of this combined treatment regimen is about $450,000 annually. And we know that that is a regimen that typically remains ongoing. So this is something that we want to alert our plans to know this is in your data, this is happening, this is likely to continue, and what can we do about it, if anything. And as we look down this list, we also see that 2 of the other claimants in that red color, meaning high risk from a financial standpoint or anticipated to be over $100,000 over the next 12 months, 2 other of these individuals are also receiving infusions. Several of them are receiving them in outpatient hospital settings, which, as we know, are the most expensive setting to receive those kind of medications. So in seeing that, we can see immediately in looking at these high cost claimants that the infusions that are occurring are a cost driver for this group. And that helps start to think about strategy for us. And these strategies can range from working with the carrier team to redirect that site of care from those expensive hospital outpatient settings to a home setting or to office, or potentially sourcing the medication in a different way so that we can still maintain the treatment that our members are receiving and not impact their care, but we can reduce any of those upcharges that the plan may be feeling when members are receiving these in high cost facilities. Or they might include something like direct contracting with a hospital, also to reduce those plan costs. So looking at those claim line details for all of our high cost claimants really helps us see exactly what's going on with each of them and helps us to develop those strategies to mitigate costs going forward. Now, after doing a multitude of high cost claim reviews with clients, we realized that we wanted to be able to recognize these issues in real time, not just once a year during our annual reviews of the high cost claimants. And this prompted us to create a proactive system in our data platform to identify high cost claimants in real time. So every month, with every data refresh that we receive, our clinicians review all of our claimants who have had a high cost claim that month. So this could include anyone who started on a high cost medication or a high cost infusion, anyone who just has a high paid amount that month. So if anyone has a paid amount of $50,000 or over in 1 month, that would prompt us to review. Anyone who started dialysis or is awaiting a transplant, or even an individual who just has a rare diagnosis that might put them as a candidate for needing an expensive gene or cell therapy. And when our clinicians review these claimants, we always approach our analyses asking the same 4 questions. So we're always looking at those claims thinking, is this cost appropriate for the treatment? Is the treatment appropriate for the diagnosis? Is the care optimized for this member? And is the plan being administered properly? And if the answers to any of those questions are no, we hold our vendors accountable by reaching out to them and advocating on behalf of our employers, which often leads to cost mitigation in those situations. I think the next slide talks about a few examples of that. We may not have time to go through all of these, but we've tried to bucket these examples into 3 main categories. So you'll see payment integrity there, clinical appropriateness, and vendor accountability. And so in those buckets are those questions that we just discussed on the previous page. So for all of these claimants, all of these high cost claims, we are always looking to see, is this cost appropriate for the service that we're seeing? And you'll see in that top bucket there's a couple examples. One that I'll just go over with us is one that occurred recently. We noticed in our monthly trigger report that there was a member receiving a medication called Keytruda, which is an immunotherapy infusion. And in this case, it was being given every 6 weeks in an outpatient hospital setting. Why it hit our triggers is because that infusion was $110,000 per infusion, which is extremely expensive. The list price for Keytruda is probably about $25,000. So we reached out to the carrier to talk about this and say, this is much, much higher than we typically see for this infusion. And in fact, we could also see in the data that the hospital in which it was being infused was billing the plan $60,000, but yet the plan was being charged $110,000. So there was already several issues occurring with that claim that we were really able to pull out from the data. So we worked with the carrier for months to move this infusion to a lower cost facility so that, again, the patient's treatment is not being impacted, but the cost of the treatment is being lessened for the plan. So by doing that, by moving that to a lower cost facility, the cost for that infusion dropped from $110,000 to $26,000 per infusion. And that one thing ended up saving the plan about $680,000 annually. Because this is a medicine that remains ongoing, this is an annual savings now year over year, as long as that person is on the plan and stable on that medication. We do also look for any duplicative claims. We don't see that a ton, which is great, but we do see that. And in fact, one case we saw recently was someone who was being billed, the plan was being billed for dialysis services twice for each dialysis session. And so we saw a block of that was occurring over the course of several months and brought that up to the attention of the carrier's nursing team. And they were able to go back then and recoup that money and refund the plan $42,000. The provider was using 2 separate dialysis codes, which is why it did not get adjudicated as incorrectly, because it looked like to the adjudication team it was 2 codes, but clinically that wouldn't be possible to get 2 different types of dialysis in the same day every session. Looking at, I'll just give an example from each of the other buckets again, just for the sake of time, but looking at clinical appropriateness, we are always looking at any opportunities to optimize care. And in this particular example, we had a member that was receiving a medication that was extremely expensive. This is an oral medication for a rare form of leukemia, and the medication is about $1 million annually. So this is, again, a medication that remains ongoing. And it became aware to our clinical team that a new tablet strength of this medication had been recently developed. And this tablet strength would allow this member to only need to take 4 tablets per day instead of 10 tablets per day. It also would decrease the cost about $60,000 per month by doing that. So we worked with the PBM for months on trying to get this switched. It would not change the actual dosage for the member. It would only decrease the number of tablets this person had to take. The PBM was quite reluctant at first. They were unaware of the new dosing. There's a bit of back and forth there that went on, but finally they were able to switch that. And now, of course, that's a win for the member because they don't have to take 10 tablets a day, but also for this plan. And by doing that, the plan saved about $770,000 again annually, because this is an ongoing medication. The last example I'll share in that vendor accountability bucket. In this bucket, we are making sure that not only are our TPAs, our carriers, our PBMs, that those vendors are administering the plan properly, but also for any vendors, any third-party vendors. So this might be some carve-out solutions or some advanced health strategies that we are implementing for the plan. We want to make sure that everything is performing as it should. And in one particular instance, we saw that someone had received a very expensive cellular therapy called CAR-T, and it came across on our claim line as over $1 million, $1.3 million. And we reached out to the carrier because this was so much higher than we would typically see for this therapy, and we requested some rationale for that cost. When their clinical team looked into it, they realized that they had not processed this claim appropriately through their transplant contract. So they reprocessed this claim, and the plan ended up being refunded $740,000, as the claim should have been closer to about $500,000, not $1.3 million. And the same can be said for, again, any of the carve-out, the advanced health strategy vendors that we're implementing. We're also still monitoring any of claims that are receiving any of these advanced strategies. So just one quick example is that we recently carved out dialysis for one of several of our groups that were having very high dialysis claims. And with this particular vendor, they charge a case rate every month in order to use their service. But we noticed for one of the members that was using the service that member was hospitalized for a month, not receiving outpatient dialysis, yet our group was getting charged that case rate. So because of that, we reached out to that vendor to say, hey, did you know they were hospitalized? We shouldn't be paying for outpatient dialysis in that month. And so they did not realize that. And when it was brought to their attention, they did refund the case rate to the plan for that month of $18,000. So we could probably spend another hour on all of the examples we have, but for the sake of time, we just wanted to review some of the examples in each of these categories and how we use those claim line details and look for this information every month, not only to mitigate these issues immediately when we see them, but also to help develop strategies so that we can mitigate any ongoing issues going forward. And then the last slide that is shared here is just that last bullet point, is that assistance with stop loss negotiations. So again, because we have access to all of those claim lines and we are able to see the treatments and the cost of the treatments for our members, when it comes time to negotiate stop loss, our stop loss vendors typically provide a list of claimants that they're most concerned about. And these claimants are the ones that will drive up the rates every year. So they send those and say, this is what we're projecting, this is what we're seeing, and why we're giving you this particular rate increase. That allows our team to then also review the claimants, all the information for those claimants, and provide our review of the claimants as well, and then to meet with the stop loss vendor's medical team to discuss what we're seeing versus what they are seeing. And oftentimes we're seeing similar things, but what's on the screen here are examples of when we are not seeing the same thing and our projections are quite different. So just even looking at that first example there was a person with multiple sclerosis that was receiving Ocrevus infusions. And they had just started receiving these infusions. And so they had just received their 2 loading doses. And now, typically for that medication, now you'll only receive it once every 6 months. But the stop loss vendor team was calculating that out, that the person would continue to receive it every month. And so their projection was based on that knowledge. And their projection then was $225,000. But knowing the clinical regimen for that particular medication, the real cost, now knowing that those 2 loading doses are done and this will only be every 6 months, the real cost would be around $85,000. So having these discussions back and forth with the vendors ends up decreasing the projections for these claimants when it's appropriate. And in some cases, removing lasers if lasers have been recommended or are already existing on a plan. One of the ones that we were able to remove is a member that had multiple myeloma, similar to the one we discussed before, receiving a very high cost regimen, again, that Kyprolis and that Venclexta medication. And they had a laser that the stop loss vendor wanted to keep on them, a $400,000 laser. But in fact, we could see that the member had received CAR T cell therapy earlier that year. And when you receive that therapy, that's a one-time therapy. You do not remain on any of these medications going forward. So at this point, having received that particular therapy, there was really no reason to keep a laser on that individual. And so they were agreeable to removing that laser for that individual. And so all of these give different examples. And again, I know we're coming up on time here, but just wanted to provide just some examples so that it makes more sense as to exactly how the clinical team is using data to help control cost.
Well, I thank you very much, Julie. Julie is the ace in the hole for the Municipal Healthcare Financing Collective. She gives this report or a similar report to the members of the MHFC every time we meet. And there's always healthy discussion about what she and her team are finding and how that can be helpful to the participants in the MHFC. So thank you, Julie. I encourage, again, our attendees who are still on the call to type in any questions that you might have in the questions panel for either Julie or Mark. I want to take this opportunity to turn it over or ask one of the county attendees here a couple of questions. Kevin Roach is the Employee Benefits Administrator for Ulster County. And Kevin has been a participant, and Ulster County has been a participant of the MHFC from the beginning. Kevin, can you give attendees a sense of what it's like to be part of the Municipal Healthcare Financing Collective? Kevin, can you hear us? All right, I think we're having some technical difficulties there. Kevin, please let us know if you can hear us. And then if you have any questions, please let us know. As soon as you are able to join us, Kevin, please do so. Julie, a question for you. So as you approach these third-party administrators with comments, questions, or concerns about the high-cost claimants, what is their reaction generally?
Generally, they are helpful. So when we approach with the types of questions that we ask, these questions are very informed on data. They're factual questions saying, we're seeing duplicate claims here billed for dialysis twice on one date of service. And so oftentimes they will write back and first of all, take it to their clinical team. But when they review this data, they're seeing the same things we are. It's just that they may have not noticed it during the adjudication process, as many of these things are auto-adjudicated. But I think because of the way that we structure these questions and because they are solely based on facts and data and not more opinionated, they have been very helpful. Usually it does take many back and forth when we're talking about more strategic moves, like trying to move an infusion or do a direct contract with a hospital. But for the most part, I think that they are helpful partners in this.
Okay, great. Mark, in the interest of time, I'm going to turn it back over to you to provide a summary of what we discussed today and to provide attendees with some contact information should they be interested in exploring the MHFC further.
Thank you, Mark. All right, so is the MHFC right for you? That's the question. So it's really simple. Do you want control of your high cost claimants greater than 50,000? Julie just went through real-time risk management and your high cost claimants. And we go by a philosophy. What gets measured gets managed. Shopping stop loss is not a strategy, is our view, right? Every year I go out, I shop it, I come back. Autonomy. Do you want autonomy? You keep your existing medical carrier, TPA, PPM, no changes required to participate in the MHFC. You have do you want full transparency of all your data and costs? Do you want stop loss premium that's underwritten by the individual municipality? In other words, not one rate fits all, right? Where everybody gets the same rate. Do you want leverage being part of NISAC? Do you want to leverage that in the 62 counties? Do you want to consider moving from fully insured model to a self-funding, your health plan, under a protective stop loss environment? Just ask for a feasibility study. We'll be more than happy to walk you through that and whether that makes sense for you or not. And if it doesn't, it doesn't. Do you want financial stability with predictable costs and protection from the market volatility? I showed you those slides where the average increase for the stop loss was below what the industry standards are. In other words, do you want protection when you have a bad year and not have to pay that in the subsequent year? Do you want to be underwritten to break even? Do you want any underwriting gains returned to you? If you want those things, the MHFC is right for you. And then ultimately, do you want long-term savings, the ability to outperform the commercial stop loss? If you do, the next steps would be to set up a meeting to discuss in more detail about the program. We are offering a feasibility study to see if the MHFC is a good fit for you so that you can decide. And then for those of you that are fully insured, more than happy to do a feasibility study with you that will include an analysis of moving from fully insured to self-funded using the MHFC model. Our contact information is here. For myself, Mark Crawford works with a lot of groups in the North Country. If you just reach out to me directly, Mark and I work together, and we'll work with you to get through all of that process. Are there any other?
Right. Thanks, Mark. I want to thank you, Mark Polinsky. I want to thank Julie Coopers. I want to thank Mark Crawford, who I didn't introduce, but who's been on this webinar, and his information is here. He works closely with Mark Polinsky and myself on the Municipal Healthcare Financing Collective. And I want to thank Kevin. I apologize for the technical difficulties. We could not bring in Kevin, but we do have some references from Columbia County, from Ulster County, and from Yates County, the participants in the MHFC, and we would be happy to connect you with them should you have any questions. This has been another program in NISAC's ongoing series of webinars designed to provide timely and valuable information for our members. These webinars are recorded and available on our website under webinars. We thank you for joining us today, and we wish you all the best. If you have any questions or comments on this particular topic or ideas for future webinars, please send me an email at mlavigene, MLAVIGNE @nisac.org. Have a great day.